Good afternoon. Good afternoon. Thank you. I'm going to share with you a pilot experience on monitoring the scale-up of family planning, integration into HIV comprehensive care centers in Kenya. And this scale-up or the monitoring came up after several presentations in international conferences and even local conferences, and one major question kept on coming up on how well are we monitoring our scale-up. As it was aimed as a country, we think of how we are going to monitor whatever we are doing in our facilities in the country. I'm doing this presentation on behalf of my colleagues, that is the NASCOP division, led by Margaret, Gitau, and FHI D60, whom we're in collaboration with this pilot experience. Monitoring scale-up of best practice. I'll give you a brief background, and basically the identification and the scale-up of the best practices has become a focus of efforts. As I've just said, as a country we've been challenged in several conferences how well we are scaling up this best practice. And we know very well we have many resources existing to support the planning and implementation of the scale-up. We already have policies, guidelines, strategies, and even a minimum package which are already in place to assist in the scale-up. However, little guidance is available for the monitoring of this process. So we really wanted to work on that. The goal for scale-up of the monitoring approach, the Division of Reproductive Health and NASCOP are collaborating with FHI D60 and the USAID to come up with an approach to monitor the scale-up of the best practice interventions. And these want to look into a rapid, low-cost monitoring exercise that can be repeated over time. If you want to monitor this year, come 2015, we still want to use the same tool, and this will determine the change in the service delivery happen. If we establish a gap today or this year, if we repeat the monitoring using the same tool, has anything been done? Again, the tool will also help us to determine the geographic coverage. If we had 500 facilities which were already integrating the services, after we repeat the exercise, how many service facilities have started the integration? Again, it will also help us to determine supporting and inhibiting factors at the facility level and how well we can put interventions to work onto essence of institutionalization of the sustainability. Has it been there? Has it improved? Or is there any efforts that needs to be put in place? And again, it will also help us to determine the challenges and the achievement in the scale-up. As there any other challenges that have been experienced, how have they been dealt with, and in case of any achievement, and the pace of scale-up. Again, we want to know, are we doing it moderate, medium, or we are doing it so well in a high way? Every integration in HIV comprehensive care centers, that is NASCOP and DRH with FHI conducted a pilot in 2008-09 on the scale-up process. And what was found out is that FP and CCC have been included in the RH-HIV integration strategy, and it also has been included in the minimum package of RH-HIV integrated services documents, also in the orientation package for HIV providers, which was developed. Then FP services offered to CCC clients which are in place is the screening. We are screening for several services, including cervical cancer, screening, TB. There is also a lot of counseling which is going on in relation to family planning and provision of methods. There is also a referral if a client may not be in a position to be offered that method at that moment. Currently, we have 1,176 comprehensive care centers nationwide. In levels 3 and level 3, we are talking about a health center, and higher levels of the district hospital, the provincial, and also the referral hospitals. and multiple models of integration are taking place, either in one-stop shop where you walk in the CCC and you are offered all your services at that one-stop shop. There is also the referrals, and it can also be mixed. You can be offered a service, then if you need another referral, you can still be referred. Steps which were involved in developing this approach, the two divisions, that is the DRH and NASCOP, formed a task force to develop the approach of the monitoring the scale-up, and this task force was mandated to outline the minimum services required for FP or for FP services to be given in the CCC clinic. And from this, they developed a data collection plan, and they also came up with a tool. And 3 sites were selected, and these were in terms of provinces. In the country, we have 8 provinces, so 3 provinces were selected. That was Western Kenya, Rift Valley, and Coast Province. Data collection was undertaken, and I'm also going to share with you a preliminary analysis which have already been done as we are continuing with the analysis. So this is just a framework of what we are looking into in terms of institutional level inputs, and here we are looking at inclusion of the integration in the policies, in our guidance, supported in the training materials that we have, in terms of budgets, activities supported in the health management information systems, client registers, that the daily activity register, or any other data collecting tool. And then the facility level inputs, we are looking to the availability of providers within the CCC who are trained in family planning services, who can assist in offer the services in the CCC clinic. Availability of FP commodities and supplies. They have a supply chain that takes the commodity direct to the CCC clinic, or how do they get their commodities, or are they available? Availability of job rates that will help them in offering the services. Supervisors oriented towards and supportive of the practice of integration. Are the infrastructure friendly to offer the service and improvements in place? And all these were the enabling factors in the leadership at all levels, which needed to show the practice of CCC clients including family planning, counseling, information, and being offered the methods or referral mechanism. The selected sites and the sampling, as I had said earlier, it was 3 provinces. And in these 3 provinces, we had to pick the provincial hospital in that province. Then in each, we were to work with 18 districts, so in each province we had to work with 6 district hospitals and the 6 health centers. In the provincial hospitals, 19 male clients were to be interviewed, but for the district and the health center and in the PGH, again, we had to interview 19 female clients. And basically, the provincial hospital is because of the high client turnover, so even getting the male clients, it was not a big problem. Data collection was in form of qualitative and quantitative. The 2 methods were used, which included a client exit interview where the team was supposed to interview 19 clients in each facility, and this was to guide whether the practice is taking place at the facility or are the client being informed about the practice. Structured interviews with CCC staffs, and this was to assess facility assessment of necessary inputs which are in place. Desk review of national and provincial level documents, whether there is sufficient support provided. Key stakeholders interviews with national and provincial stakeholders, whether there is any supportive leadership. These are some of the preliminary results I would like to share with you. And basically, this showed that at the province level, we were looking at the high, medium, and low level. And again, I would want to tell you that as we were selecting even these facilities, we wanted to know, the selection was in terms of a high-performing facility, a medium-performing facility, and a low-performing facility. So basically, as you can see here, what is showing is that at the province or the provincial general hospitals, there is medium and low performance. As a district, at least you can see there is a high performance. However, it is still not all that good. Health center, again, we couldn't manage to get a high performing, but still we are still doing the analysis, and the overall showed that there is still a lot that needs to be done. But the long-term goal is to have all these facilities having a high performance in terms of integration. So in terms of provinces, as you can see, Coast Province, still there is a gap. Western Kenya, the medium performing should be started out. In the Rift Valley, they were more or less the same, but the low performing still starting out. And in the overall, you can still see it shows that there is a lot that needs to be done for them to be high performing provinces in this best practice. The supporting factors in the preliminary results, facility assessment shows little correlation between inputs and level of performance. Basically, supervision was very strong at all facilities, as most of the facilities reported that there is internal and external supervision which takes place frequently. Some even could report on a monthly basis as an internal supervision. Most methods are provided either within the CCC or within the facility, so there is a bit of referral. Contraceptive availability at the CCC are challenged, especially the long-term methods, maybe due to the skills involved in the long-term methods. However, the short-term methods were well being offered in the CCC. And proportion of service providers trained in family planning is similar. In each CCC you could go into, there was a provider who was already trained in family planning, in provision of family planning services. Key informants indicated the existence of adequate strategies and documents, which are in place, and they are in the provinces, the region, and the national offices. However, there is need for adequate dissemination and the orientation of service providers to these policy documents. They don't have a wide knowledge on what is inside these documents. And inclusion of integration into the service curriculum, we also showed that most of our new qualified staff from the medical school and also from our medical training centers, they are very little knowledge in relation to integration. Possible conclusion and consideration, more focus needs to be put on provincial level facilities. As you know very well, they were not reported to be high performing yet, and client flow is usually very high in these provincial hospitals, and they are also considered to be our training centers. Then undertake the monitoring exercise country-wide to better understand the performance at the national level, because maybe these two provinces may not give us a good source. What are our next steps? We need to continue analyzing the data, review and finalize the data with the task force, and share with the larger team, identify lessons learned, both with the monitoring approach and with FTCCC services in Kenya, and then discuss the next steps with the stakeholders.
The University of North Carolina at Chapel here. His topic is differences in reported implementation of FP integration, evidence from providers and clients in 5 urban centers in Kenya. Welcome, Joshua.
Thank you. Taking the last spot before lunch is a tough position, so I'll try to be as brief as possible to respect your time and appetites. So, again, my colleague Paul Kuria presented some results from the Tupange MLE baseline survey that was conducted earlier this year. And so when we thought about what else we could contribute to this conference, we tried to, instead of looking specifically at results, try to take some of the data that we had to talk a little bit about measurement. More broadly, looking at how integration is measured. So what I'm going to do today is present a little bit from 3 different data sources at the facility level that we conducted as part of the baseline, and then 1 population level data source. And we're going to look at integration of FP within two different service lines, a reproductive health service line, in this case child health, and then an HIV-related services. We chose those two because we thought child health was a highly utilized service line. It offered a lot of opportunity for interaction with women who might have a need for family planning, and of course, HIV because it's the theme of the conference. So the data sources again, from the facility level, we have the 2011 Tupange MLE Facility Service Delivery Point Survey that was conducted by our partners, Kimri, in 5 urban centers in Kenya, so that's Nairobi, Mombasa, Machakos, and Kakamega. It's a nested sort of service provision type survey. We selected facilities. Within the facilities, we did facility audits. We interviewed service providers, and we did exit interviews. We got about 280 facilities, around 700 service providers, and about 4,000 exit interviews. From the population side of things, I'm going to use data from the 2010 baseline household survey. The purpose of the monitoring, learning, and evaluation program is to provide program-relevant data for the Tupange program. So in order to do that, we conducted a representative population level survey in those same 5 urban centers in 2010 with the Kenya National Bureau of Statistics. We interviewed overall about 9,000 women in Kenya. So the analysis that I'm going to do today is descriptive tabulations. For the facility survey, we're limiting it to the sample of facilities that were defined by the program as being strategic. The goal of the Tupange program is to increase the quality of care in facilities that treat the urban poor. So the definition of strategic in this case is a combination of the facility's volume and its geographic location that would allow it to treat large numbers of the urban poor. And again, the data that I'm presenting on the providers and the exit interviews comes from those same facilities. For the population level survey, we have women who had gone for a child health visit in the last 3 months, or women who had gone for HIV tests in the last year. So again, these are 2 separate surveys. There's 3 data sets from the first one, and then 1 from the population level survey. So for the facility level surveys, we're going to show a breakdown by managing authority, so public on one side, private on the other. That's really not to draw any distinctions between the two, but just to kind of present an extra level of detail to the data. So first, looking at the percent of facilities that offer child health services, you can see it's universally very high. Not much of a surprise there. Again, this is of the facilities that also offer family planning, the ones that facilities on the left, providers on the right that have the capacity to offer child health services. Again, looking at those facilities that offer HIV services, again, universally high, sort of what you would expect. Facilities on the left and providers on the right. So what we did is in each of these different surveys, we asked the facility in charge of this what normally happens when a woman comes in for a child health visit if she's interested in family planning. The response that we coded as sort of the good response for integration was that the woman would receive information or counseling on the same day as her child health visit. And so you can see on the left-hand side, you've got over 90% of both types of facilities reporting that every time that a woman comes in for child health services, if she's interested in a method of family planning, she'll get it on the same day. For the providers, what we asked them was, while you are providing child health services, do you routinely or generally provide information about family planning? And again, as you can see, the providers largely responded in the affirmative. So that's sort of how we operationally defined integration for these 2 surveys, and this is child health. Looking at HIV-related services, again, it's the same sort of what you would expect. High levels of reported integration from both the facility side and the provider side. So that's sort of the facility side of the data that we have. So we wanted to also have a look at what the clients themselves are saying. So we took the client exit interviews from these same facilities, and we asked the women questions about whether or not they received family planning services as part of the child health service that they had gone for, or the HIV-related service. So again, on the left, you've got around 900 women who went in for a child health visit, and you have low levels, in the blue you can see low levels of reported family planning information. So these women are saying that by and large they did not receive family planning information at the time of their visit. And again, the women, the sample size is lower for HIV-related services, but similar results. So we thought that was interesting compared to the facility level results. So at this point, we brought in the population level data that we have. Now again, remember this is a different survey, but it's women in the same urban areas. So again, among the women that we surveyed for the population level survey, those that had gone for a child health visit in the last 3 months, we asked them if they received any family planning information at the time of their visit. Again, you can see that in the orange there, those are the women who reported that they had in fact received family planning information at their child health visit. And on the right-hand side, we asked them if they had gone for an HIV test in the last year. And you can see that there again, it is, there's a low level of reported integration from those women. So we tried to think a little bit about what that meant. Again, when we were conceptualizing what we wanted to do for this survey, we thought it would be interesting to talk a bit about measurement of integration. And I think that this morning we had a very nice lead-in from Dr. Askew and from our colleagues at UCSF that spoke a little bit about different ways of looking at measurement. So using these different examples, what we found is a high level of consistency from the client side. That is to say that the women who were actually clients at facilities that we interviewed as they were exiting facilities had low levels of reported integration. And that was consistent with the population level data that we had. So we had women who had also gone to facilities in the same area reporting the same thing. So those two were consistent. And then we also had high levels of consistency between what the facility in charges were reporting in terms of integration and what the providers of those facilities were reporting, what the providers of those facilities reported for integration. And so we thought that the consistency between those two different groups and then the fact that there was a gap between them was an interesting finding. Again, there's a number of possible explanations. It's from the client side, it's possible that women are not fully understanding when they're offered integrated services. Messages around birth spacing, child spacing could be confused with family planning information. It's possible that providers are pre-screening women for integration services. And for the facility survey, the way the question was phrased was, if a woman requests family planning services, what happens? So it's possible that because some facilities are not being as proactive in integrating family planning with other services, rather than waiting for the woman to come and request the service itself. So what's to do about this? We thought that this spoke to the need for kind of further qualitative interview with women, and what is their perception of family planning service? Are they agreeing with what the providers are saying that they are receiving these services, but they're just not understanding them in the way that we phrased the question? We did not conduct an observational or mystery clients component of our facility survey, which is also a good way to look at some of this information. And it also calls for further examination of the data that we have, and so that's why we thought it was important to present these results here, because we certainly look to the larger reproductive health and HIV community for ideas about how we could explore this data set that we have a little bit further. So, thank you to the Bill and Melinda Gates Foundation and our